work at the Imperial College London Diabetes Center, which has branches in Abu Dhabi and Al Ain. And we follow a huge number of patients with diabetes from all over the UAE. And we felt we were in a good position to validate or to try to validate the new IDF DAR Ramadan risk assessment tool to look at patient-reported outcomes in people with diabetes. Okay, so as we all know, the DAR and IDF updated the guidelines in January 2021, a year ago. I will not go through the reasons why they were updated because this has been covered very nicely by Dr. Bashar and Dr. Hassanein. So the aim of our study is to validate the accuracy of this new IDF DAR risk assessment tool and to see if it can predict the adverse outcomes of fasting of Ramadan in people who are fasting. I'm presenting the results on behalf of my colleagues in ICLDC shown on this list. And so the study was approved by our ICLDC Research Ethics Committee. As we all know, Ramadan last year was between 13th April and 12th May. And we recruited our patients during the month before Ramadan, which is a very busy month for our center. So the plan for our study was simple. It had two parts. The first part is a pre-Ramadan assessment. And here we tried to stratify the risk using the new DAR risk assessment tool. And then post-Ramadan, we wanted to contact these patients to ask them, first of all, whether they were able to fast and how many days they fasted. And if they did not fast, what was the reason? And specifically we asked them about complications like hypoglycemia and hyperglycemia. So the inclusion criteria, similar to the previous studies reported here, any age 15 years or over, with any diagnosis of diabetes of any type. We included any patient who made a decision to fast this coming Ramadan, or at least were thinking about fasting but not sure. We only excluded patients who made a decision before Ramadan that they're not intending to fast. So we gave patients information about the study and we gave them the information leaflet. If they agreed to take part in the study, we asked them to sign a consent form. And once they have signed the consent form, then from information from their own records and from asking them, we completed a risk assessment sheet for each patient and gave them a risk according to the new risk assessment tool as has been shown before. And we gave the standard advice as recommended by the DAR recommendation about fasting. Post-Ramadan, we used a questionnaire. So we contacted these patients either by telephone or during their first clinic visit after Ramadan. And we asked them if they fasted, how many days they fasted, if they did not fast, what was the reason? Is it hypo? Is it hyper? Is it non-drug diabetes related? If they had hypos, we took details about this, hyperglycemia, hospital admission, and so on. So that was the post-Ramadan assessment. So now to the results of our study. So the total number of patients who had a pre-Ramadan assessment was 659. And out of these, we managed to contact 647 patients to do the post-Ramadan assessment with a 98.5% follow-up rate. The age, mean age was 53.5 years with a range of anything between 16 years and up to 94 years. Gender distribution was roughly equal between males and females. Distribution between the three risk groups was like this. So just over half of our patients were on the low risk group, which obviously reflects the type of patients we see. Just over a quarter were on the moderate risk group and 1 in 5 were in the high risk group. As expected, the majority were type 2 diabetes with just about 92%, and 8% had type 1 diabetes. That's 53 patients. The duration of diabetes, 55% of our patients had a duration of less than 10 years, while 45% had a duration of 10 years or more of diabetes. Regarding hemoglobin A1C pre-Ramadan, 61% of our patients had a relatively good control with an A1C of less than 7.5%, and 13.6% had poor control with an A1C of more than 9%. Looking at the medications that have the potential to cause hypoglycemia, a third of our patients were on insulin, just over a quarter were on sulfonylurea, and just roughly about 40% were not on either. Looking at the specific complications before Ramadan, 1 in 5 of our patients, 20%, had some form of macrovascular disease. And about 5% of our patients had chronic kidney disease with an estimated GFR of less than 60. So now going to the post-Ramadan survey. So the first question we asked our patients was whether they fasted during Ramadan. And obviously the vast majority of our patients did fast for the whole 30 days. This is 87% across the whole cohort. But when you look at the different risk groups, 94% of the low risk group fasted the whole 30 days, but the number who fasted 30 days were roughly similar in the intermediate and the high risk group at 79 and 78%. Only 2.8% fasted for fewer than 7 days of Ramadan. Now looking at hypoglycemia, so the number of patients who did not report any hypoglycemia was highest in the low risk group, and the percentage went down in the intermediate and the low risk groups. And as expected, of course, on the other side, those who reported any hypos, it was the reverse. So this was low in the low risk group and increased in the intermediate and the high risk groups. We looked at the number of hypos reported by the patients during Ramadan. And if you look at those who reported between 1 and 4 hypos and those who reported 5 hypos or more, the numbers or the percentages were higher going from the low risk group to the intermediate and to the high risk groups. The severe hypoglycemia, we defined it as a hypoglycemia in which the patient needed help from another person. And this was a rare event overall in our study. Only 6 patients reported this, 0.9% of the whole cohort. So 1 patient in the low risk group, 3 in the intermediate, and 2 in the high risk group. We compared the high risk group against the combined intermediate and low risk group in terms of those who managed to fast the whole 30 days with no hypoglycemia. So in the high risk group, the percentage was 60%. In the intermediate and low risk group combined, it was 83%, and the difference was highly statistically significant, suggesting that the high risk group is different from the other 2 groups. Now looking at hyperglycemia, which we defined as reported at least 1 episode of self-monitored glucose, which was above 250 milligrams per deciliter, and the number increased progressively from the low risk group, 3%, to the intermediate, 15%, and the high risk group, 21%. Only 1 patient in our study needed hospitalization. This was a patient in the high risk group. This was an insulin-treated type 2 diabetes patient, needed hospitalization because of uncontrolled hyperglycemia. None in the intermediate or the low risk groups, and no cases of DKA were reported in this study. The next thing we wanted to do was to do a multivariate analysis. And what we wanted to do here is to look at the various risk factors in the risk assessment tool to see, to ask these questions, to see which of them, first of all, predicted the ability of the patients to fast for the full 30 days, and which of these factors predicted the probability of having hypoglycemia. So we looked at the ability to fast for 30 days, and what we found here, and to be honest, we didn't expect this, but for some reason, males were more likely to fast for the full 30 days compared to females, roughly double. Patients with type 1 diabetes, I think this is expected, were less likely to fast for the whole 30 days. The odds ratio here was 0.35. And patients who are on basal bolus insulin were less likely to fast for the whole 30 days with an odds ratio of 0.21. None of the other risk factors actually predicted the ability or the probability of the patients fasting for the full 30 days. Now looking at the probability of having any hypoglycemia, and here, again, patients, males, were less likely to report hypoglycemia, probably for maybe, I don't know, cultural reasons. Patients who have type 1 diabetes are more likely to have hypoglycemia with an odds ratio of 3.3. Patients who take sulfonylureas or imagine were likely to have hypoglycemia. I think this is expected with an odds ratio of 2.29. And patients who are treated with either basal insulin or basal bolus insulin, again, were more likely to have hypoglycemia. As I mentioned earlier, 1 in 5 of our patients had macrovascular disease. And what we wanted to do is to compare these patients to patients who did not have macrovascular disease to see if there is any relationship between having this MVD, vascular disease, with the ability to fast for 30 days or the probability of having hypoglycemia. And as you can see here, there was actually no difference between the two groups, those who had vascular disease and those who did not, in terms of fasting 30 days or in terms of having hypoglycemia. We did the same thing for the relatively small number of the patients who have chronic kidney disease with an eGFR of less than 35. Here, we only had 35 patients. And again, this did not predict the ability to fast for 30 days and did not predict the ability or the probability of getting hypoglycemia. And lastly, in this graph, we just wanted to show you that if you look at the different groups of risk scores going from we paired them 0 to 2, 3 to 4, 4, 5 to 6, and so on. And as you can see here, at least within the range of risk scores we are likely to see commonly in clinical practice, appears to be some relationship between the increasing risk score on the DAR and the increasing risk of hypoglycemia. So to summarize, I think our study suggests that the new IDF DAR risk assessment tool is probably predictive of both the ability of to fast for the whole 30 days and probably does predict the risk of having some complications of diabetes like hypoglycemia and hyperglycemia. We did identify a higher risk in patients with type 1 diabetes to have diabetes complications like hypo and hyperglycemia. I didn't show that, but we showed hypoglycemia, and also the risk of having hypoglycemia in people who are treated with insulin, regardless of whether they are type 1 or type 2, and those type 2 patients treated with sulfonylureas. We also felt that there was an observation that the intermediate risk group is probably closer to the high risk group than to the low risk group. And lastly, although the number of patients with chronic kidney disease was small, but I think we did not see a difference that the macrovascular disease or chronic kidney disease predict the risk of fasting the full 30 days or the probability of having hypoglycemia. And thank you very much for listening.